Thank you very much. Thank you for the introduction. I need to express my pleasure and honor to Professor Kotsis for inviting me to participate in this meeting and especially in this session with very esteemed and important guests. Although we enjoyed some very well presented topics. However, I think that the last one is a hot topic that carries huge potential in the modern cardiovascular medicine. Actually, traditionally, we have focused on the management and control of low-density lipoprotein. And the guidelines target to mostly on this lipid type. However, even if we manage to control appropriately and according to guidelines, the LDL levels, still there are some of our patients who carries a residual risk. So there are some parts of the puzzle that are missing, and one of this part is lipoprotein A. Lipoprotein A is a type of LDL, which includes and it has a core of hydrophobic lipid core, which is surrounded by apolipoprotein B, just like LDL. And this molecule, this particle, is a carrier for the hydrophobic core to travel across the aqueous environment, which is the bloodstream in the arteries. However, lipoprotein A also carries and is surrounding by another protein, which is called apolipoprotein A, moiety covalently bound with ApoVita. ApoA is a unique plasminogen-like glycoprotein and is produced only by our liver. And important sites in these particles are these folds called the crinkly repeats for type 2 folds that are very important and are very crucial in the activity of this particle, in the pathophysiologic role, and in the way this particle interact with other components and other receptors. So any isoform in this particular crinkly repeats might have an impact in the prognostic and pathophysiologic role of lipoprotein A. In contrast to other type of lipids, lipoprotein A is one of the most heritable human quantitative traits with up to 90% heritability, very slightly, without any important impact from diet or environmental factors. So it's strongly dependent from one gene, LPA, so it's a monogenic type of lipoprotein. And here you can appreciate the course of research interest since the discovery of LPA in 1960. So you see this flat line, then blast off in research interest. And now, after this down curve, we can see that lipoprotein A has gained attention from the research community and with an increasing number of publications over time. This is a very important study from Denmark, a general population study, which has included approximately 80,000 white individuals. And this study has nicely characterized the amount and the importance of LPA in this population. So you can tell that approximately 20% of the general population carries increased levels of LPA. And this another image that characterize the population across the planet and across several all the components worldwide. So you can tell here that African population has the largest percentage of high LPA level, in contrast to Chinese, for example, who only 10% of the population carries a high level of LPA. So this is LPA with the critical domains. And you can see here that these molecules implicates in many pathophysiologic pathways in cardiovascular diseases, because this molecule can interact with adhesion molecules and the E-selectin, and this provokes an adhesion of monocytes to endothelium. It also implicates in thrombosis, because it's one of the pathophysiological pathways that they might compete plasminogen and reduce fibrolysis. But one of the important characteristics of this particle is that it's a very small particle in diameter and can freely flux across the endothelial barrier and retained by the endothelium. And of course, furthermore, change its the normal structure of the endothelial layer. Some of the mechanisms of actions you can see in this slide. LPA is a key process. It's a key process in atherosclerosis. Might induce foam cell formation, a proliferation of smooth mass cells, interacts with and provokes plaque inflammation and instability. But the main action is that carries oxidized phospholipids, which are considered pro-inflammatory and pro-atherogenic. So on this, on the right, in this nice study, you can appreciate the strong relationship among the measured oxidized phospholipids in the serum with the levels of LPA. So these two components are very strongly related at the pathophysiological level. And this is probably the most important feature that interacts with the vessel wall and goes through the pathophysiology of atherosclerosis in patients with increased LPA levels. However, initially, we should mention that during the evolution, the LPA had a protective role in the human evolution, because the initial role was to contribute to wound healing, transporting cholesterol to sites of injury for cell replenishment, and to limit the bleeding via attenuated fibrinolysis. However, let's say, physiological activities during specific pathophysiology framework turned into harmful effects of lipoprotein A. So we go back to the this large study, Copenhagen City Heart Study, which has nicely showed that increased levels of LPA are strongly related with increased risk of myocardial infarction during across the lifespan. And this data are data adjusted by age and sex, and other multi variables cofactors. So you can tell here that patients, individuals with very low levels of LPA, less than 5, have the lowest risk, in contrast to individuals with LPA levels more than 120, where the risk is blasted off. However, the threshold of high risk is much lower than 120, is 50 in this study. LPA level over 50 milligrams per deciliter is considered that bears higher risk in general population, even if the LDL cholesterol level are lower than 70 milligrams per deciliter. So you see that you can see clearly here that the risk is higher beyond LDL levels in this study. Here also, you can, in the same study, you can appreciate how the risk of LPA, of certain components of cardiovascular spectrum increases accordingly with the increase of LPA level. So you can tell the increase in risk of myocardial infarction, in heart failure. The relationship with ischemic stroke is not that strong as it is in myocardial infarction and heart failure. You can see here the relationship. However, beyond the atherosclerotic disease, there is a strong relationship with aortic valve stenosis. You can tell here that beyond the fifth quartile, the increase of risk in aortic valve stenosis progression is really high. Similarly, here you can tell here the effect of LPA on risk of major cardiovascular disease. But please pay attention in this graph, which is the effect of LPA on risk of venous thromboembolic events. Notably, LPA does not offer any additional risk in venous thrombotic events, in contrast to arterial thrombotic events and cardiovascular risk. So this is something that we need to clarify and is very obscure regarding the data we have with the LPA. On top of these findings, we can see here that the more severe is cardiovascular disease, the higher are the levels of LPA in our patients, which I mentioned before, and I repeat, they are not affected by diet, or by environmental factors. Similarly, you can see that LPA here, even more than 30 milligrams per deciliter, exhibit a higher risk for not only for cardiovascular events, but also for for the need for revascularization treatment as CABG and PCI. And this is a recent study that indicates and reinforces the data I showed before in the previous slide, that Black people bear higher LPA levels, and with a less risk in East Asian people. However, apart from the ancestry-specific characterization, the higher are the levels of LPA, the higher is the risk for future cardiovascular event. And this is also a very nice, although an older study published in JAMA, pooled a genetic analysis of 3 large population study in German that also indicate what I said before, that there is a correlation of risk with levels of LPAs, but also there is an inverse risk with the number of Kinkel repeats, which I described in my first slide during my presentation, which also bear the number of Kinkel repeats bear an additional risk probably in this lipid disease of high LPA. This is a very recent published pooled analysis published in JACC, which combined 5 major population studies in USA, included approximately 30,000 individuals, which also indicates this higher risk of LPA in future cardiovascular risk. This pooled analysis indicate that the LPA levels over the 75th percentile bear a higher risk, and this is the threshold, which in this pooled analysis, levels of LPA more than 25 milligrams per deciliter are attributed to the higher risk. And this relation is similar even if the analysis was based on sex, on race, or regardless the LDL cholesterol category. This relation reinforces by the incidence of diabetes, so diabetic patients with higher LPA bears a higher risk for cardiovascular events. And this is another important finding to keep in mind. In these population studies, the authors noticed that the levels of LPA in men remains approximately constant through the lifetime. However, in women, in age in over 50, the LPA might be increases. So, considering that the risk of increased LPA levels are similar in both sexes, so there is a value to measuring lipoprotein A, more common compared to men in age over 50. This is another important study, ProCardi studies published in New England, which used a very sophisticated and novel at that time gene chip containing approximately 50,000 SNPs. And this analysis indicate that 2 specific variants of SNPs carries the highest risk of cardiovascular morbidity and mortality in the general population. So the polymorphism of LPA is very important apart from the LPA levels. However, this polymorphism might affect either the levels of LPA or the number of crinkle repeats, which, as I said before, are important in the prognosis and the outcome of this patient. And in this very detailed and important statement of a European Atherosclerosis Society, you can appreciate that since then we have also indicate other variant of LPA gene that might bear an additional risk in patients with high LPA levels. So we can tell now for sure that LPA is a new inherited lipid disorder. And this is data from a landmark project, UK Biobank, that carries data from almost 500,000 participants of the UK. And this data confirm that 20% approximately of participants with atherosclerotic disease have lipoprotein concentrations, LPA concentrations higher than 150 nanomole per liter. So importantly, very high LPA levels, more than 180 milligrams per deciliter, identify individuals with similar risk with the ones with untreated heterozygous familiar hypercholesterolemia. So this is a very important gap in our lipid guidelines management. And here, from the same consensus, you can appreciate very nicely that according to the different cardiovascular risk scores, according to the score calculator, the existence of higher LPA re-stratificate the individual. So this is very, very impressive that here individuals with very high LPA, more than 150, even if there might be in a very low score risk, carries risk that are very high, the highest risk. But let's move to aortic stenosis. Aortic stenosis also it's a disease that is influenced by the progression of this disease is influenced by the higher level of LPA. You can appreciate very nicely in this study with is a secondary finding of astronomer rosuvastatin study on aortic stenosis. And this is a Manhattan plot in another very important study with indicate SNPs that may affect more the progression of aortic stenosis. Probably high LPA is associated with both microcalcification and macrocalcification because it interacts with osteopodin in aortic valve and promote the faster progression of aortic stenosis. And we should keep in mind. And another finding that we cannot explain so far is that, and it was a surprising finding, is that it's another large population study. LPA had an inverse relation with diabetes mortality and incidence of diabetes. And the lower LPA were related with higher incidence of diabetic. This is something that I should mention, but I cannot explain with the existing literature so far. So there are many questions raised by the by the European Atherosclerotic Society regarding the epidemiological aspect, risk assessment. Also, there are many measurement issues, mass or molecule. And of course, absolutely, there are many questions regarding the management of LPA. So far, we have no targeted treatments to LPA. However, things are optimistic because there are many targeting, many novel therapies developing which target on LPA hepatic synthesis that are now tested in the very important clinical trials. The only FDA approved so far tool is the lipoprotein apheresis when the LPA are very high and the cardiovascular risk is huge. Although you all are aware that lipoprotein apheresis is a very complicated procedure. A few words for mipomersen, which is an antisense oligonucleotide targeted hepatic apovita mRNA, which is approved for homozygous, only for homozygous familiar hyperlipidemia, and this might also reduce LPA. There is this Horizon secondary prevention trial. Results were clarify what we should do with these patients. So, when we should get and measure LPA. According to the latest European Atherosclerosis Society consensus statement, LPA should be measured at least once in adults to identify those with high cardiovascular risk. Screening, which also recommended in patients with a history of ischemic stroke or a strong family history of premature atherosclerotic disease. And however, there is also a cascade testing for high LPAs is recommended in the setting of familiar hyperlipidemia, family history of very high LPA, and personal or family history of atherosclerotic disease. There are also several issues with LPA measurements. The laboratory should use an LPA assay that is sensitive to ApoA isoform and traceable to official reference material, should be in molar units and not in milligrams, and clinical guidelines should consider using risk thresholds with gray zones. Early in these patients, early risk factor management is recommended and is mandatory and should be aggressive. Among patients with high LPA risk, with high LPA, all cardiovascular risk factors should be comprehensively addressed according to guidelines. Lipoprotein apheresis can be considered in patients with very high and very progressive cardiovascular disease, despite optimal management. Niacin is the medication that might reduce LPA. However, 2 studies were negative regarding the outcome, the final outcome of the patient, so is not recommended for LPA lowering. However, we have data from Fourier and Odyssey outcomes that PCSK9 inhibitors might reduce LPA. A very recent study from real-world data resulted that PCSK9 inhibitor might reduce even 45% the levels of LPA. In conclusion, LPA is a genetically determined risk factor appreciated so far, but strongly related with atherosclerosis, coronary artery disease, thrombosis, and aortic stenosis. Should be measured at least once in our lifetime. Whether the reduction of LPA levels might confer to an improvement in cardiovascular risk is a matter of research. And of course, we have a lot of things to clarify regarding the pathogenicity and the pathophysiology of LPA in cardiovascular spectrum of diseases. Thank you very much.